much, Professor Joe, and thank you very much, Professor Peter. Just give us a very good presentation. And for a new adjuvant, if the patient is, driver gene mutation negative patient, give IO plus chemo. But for driver gene positive patient, it's really a dilemma because adjuvant ADORA study showed us that 5-year survival is more than 85%. So it's very high percent of 5-year survival. So we don't have that confidence to open a trial for new adjuvant to beat this very good results. But our goal is not just survival when we use the new adjuvant therapy. Some patients, it's very difficult to perform surgery because of maybe they are T4. So we want to, download the stage, maybe it's more easy for us to perform surgery. More people have R0 resection. So sometimes we will use that. In my clinic, I will use chemo plus TKI. We want to better results, but we don't have confidence to have really survival benefit. But we believe that if the patient have have surgery, maybe they have benefit from our surgery skills. So I still have a question actually. For ADORA, there are just two cohort. One is after chemo, we use TKI, and chemo after placebo. In the first group, sometimes we don't use chemo, just TKI, and the results shows they have the same results. But if you just when you use chemo and then TKI, you delay the using of TKI because you first chemo. So my question is, do you think it's reasonable? You just mentioned the combination after surgery. We give the patient the combination TKI plus chemo together. Maybe it's they can use TKI very early. Maybe it's a better way. So what's your comments, Professor Peter?
I'm looking forward to see what Xiaolong will say, but it's interesting because Luis Pazares, our colleague from Spain, is always very verbal, very vocal about it, because he says, why, as you say, you need to give osimertinib and chemo. Why don't you give them in the same time? We have the FLAURA2 data. It works very well. So even if we don't have evidence-based data, it's easier for the patient. It's probably better for the disease. Well, yes and no, we don't know. Probably the neo-ADAURA data will tell us that what we expect is not the same in early disease as compared to metastatic. You've seen the benefit in FLAURA2, it's huge, but you will not see it in the neo-ADAURA. So it looks like biology might be slightly different. So if you want my opinion, I don't think it's deleterious. However, again, if Baselga were here, he would probably tell you, you don't know. So don't do because you don't know. You might ruin the efficacy of chemo, or you might minimize the efficacy of TKI because you don't know what you do. But basically, I would say probably it's not detrimental, but I'm not sure it's beneficial. And remember, it's pretty more toxic. When you give Osi and chemo, you have more neutropenia, more anemia, more complications. So is it really good to take the risk knowing that TKI is not curative, right? It's more cytostatic than cytolytic. So I'm very, I would say, usually conservative. I use evidence-based data. So they probably would do it this way, right? And not, so sequencing, right? First the chemo, and then the TKI, because the worst would be not to be able to do that because you decided to do your own experience. So I don't like the idea of doing more than what the data tell you. What do you think, Xiaolong, about it and the colleagues?
Thank you very much. So for your in your practice, do you use more just TKI adjuvant or chemo?
For the chemo, no, I keep the chemo. We have the same question, with the wild type and chemo IO. If you look at the subgroup of patients not receiving the chemo, they still benefit from osimertinib in ADAURA, and they still benefit from immunotherapy, for example, in the PEARLS trial, okay? But this is not prospectively assessed. These patients do not receive chemo because they recover slowly from surgery or because they developed renal insufficiency or something. So it's a selected group. And usually it represents 20% of the patients, right? So it's a biased, non-balanced subgroup post-hoc analysis. So none of the trials under the question is, can you skip chemo in patient, but they just address this small subgroup. So and again, being conservative, the evidence-based data tell you that you still have to give chemo in more than 4 centimeters tumor and positive. So I give chemo before IO or chemo before osimertinib or even before alectinib in ALK-positive disease in the adjuvant setting, because I'm convinced chemo is curing some patients, right? It's curing 5 to 10% of the patients. I don't know about the others. It's a very religion kind of thing, right?
Thank you. Thank you very much, Professor Peter. It's reasonable. And thank you very much, Professor Zhou, to give this opportunity. Thank you.